At the Targeted Therapy and Lung Cancer meeting this year, I have the opportunity to discuss really a number of kind of non-TKI based therapies for EGFR. And this has really been kind of years in the making. Obviously, since, you know, the over about 15 yeah, now 15 years or so, we've had really TKI or tyrosine kinase based therapies for EGFR mutant disease. And, there was always a question of would we ever have anything beyond that? Some of the early agents, we do have monoclonal antibodies that are approved in colorectal cancer and were briefly approved in squamous that target EGFR, but they were never really as effective, anywhere near as effective as the tyrosine kinase inhibitors. So over the years, we've developed better tyrosine kinases. And so what I think is really exciting is we've had a number of studies either published or presented within the last, I'd say, 4 or 5 months that are likely to change the landscape of how we treat EGFR mutant disease in the coming months. In fact, we may have an approval relatively soon, given the PDUFA dates for the FDA. But and so my talk really focuses on where do these agents fit. So I think kind of the first take-home message is we actually do have agents that will play a role in the treatment of EGFR mutant disease, and that's good news for our patients. So the first agent that I really am going to touch on is a bispecific antibody against both MET and EGFR. It's called amivantamab. It's actually FDA approved for EGFR exon 20 insertion mutant patients, but we've known that it has activity after osimertinib since 2019. So, 5 years later, we will now have an approval in that setting where we had data 5 years ago. So it's been kind of a long path for its approval in typical EGFR mutations, but I think we're nearly there. And so there were kind of 2 major studies that have looked at amivantamab in kind of a phase 3 setting. The first was actually in the first-line setting, combining it with another tyrosine kinase called lazertinib, which is also a third-generation irreversible TKI, similar to osimertinib. Does have a slightly different side effect profile, potentially has more neutropenia, definitely increased risk of thrombosis, and so anticoagulation is required. And so one of the questions was asked, well, what if we move amivantamab plus lazertinib versus osimertinib in the first-line setting? And I think to date, that was the Mariposa study. To date, the data that's been presented has shown that there is a progression-free survival benefit with a hazard ratio of 0.70. And, a benefit of about 6 or 7 months of progression-free survival. There were benefits across all subgroups. The overall survival data is immature, and this study raises some questions in the field of should we be using these agents in the first-line setting? And some of those questions involve, is lazertinib adding something to amivantamab, as we'll get into in our next trial, and also the toxicity, the higher toxicity we may see with this combination, as well as the fact that the question, there was no crossover allowed to amivantamab or amivantamab laser or lazertinib, which raises the issue, not, I think, as we'll see, that amivantamab should be part of a patient's treatment course. So this trial won't answer that, because essentially what this trial is saying is amivantamab first or never, right? And so really the comparison should be amivantamab first versus amivantamab later. And so I think that's still a debate, and I think it will be a debate actually at the Target Lung meeting of whether we should be moving this to the first-line setting or sticking with tyrosine kinase, such as osimertinib alone in the first-line setting. I think, which is very exciting, and I think it will get a lot of uptake, is there was a trial called Mariposa 2, which looked at patients that then progressed on osimertinib, and this combined chemotherapy in the second-line setting, which would be a standard of care, amivantamab plus chemotherapy, and then amivantamab plus chemotherapy plus lazertinib. There was some modifications to this study. In fact, because of toxicity, they weren't able to give lazertinib up front with the chemotherapy and amivantamab. It had to be added in later parts of the study at cycle 5. And so, interestingly, what they found was a couple things. One is that compared to chemotherapy, both the amivantamab chemotherapy and lazertinib, amivantamab, and chemotherapy were significantly better with hazard ratios of 0.48 and 0.44, respectively. The response rate was dramatically higher, so 36% for chemo. Whether it was chemo-ami or chemo-ami laser, 64 and 63%. Clearly, increased duration response. What they did notice, though, was that in the lazertinib arms, there was significantly more toxicity than what you saw for the amivantamab chemo arm and chemo as well. So there does seem, and then I think what was quite dramatic was the rationale originally, because remember I told you in 2019 we had data for amivantamab alone. The rationale for adding a TKI was this issue with potentially intracranial with brain metastasis, and would amivantamab alone be effective against it? Interestingly, they showed both in patients, in both intracranial progression-free survival was almost identical, regardless of whether you had lazertinib or not. Both were better than chemotherapy. And then if you even took patients that had a history of brain mets and no brain radiation, again, this was identical, suggesting that lazertinib is really not adding a lot in terms of CNS prevention and treatment. And so likely what we'll get is in the second line standard, a new kind of non-TKI based regimen, where it would be chemo with the amivantamab. So that's obviously good news for our patients. So I think the take-home message is that amivantamab will play a role in a patient's treatment, whether it's first line, which I think is more debatable, or second line, where I think there's very little debate after osimertinib that this would be a new standard of care. There are, and I won't get into it today, but there are some other emerging kind of EGFR MET bispecific and trispecific antibodies that are being tested. Those are kind of earlier along, but something to keep in mind that we may have more drugs in this class, and maybe we'll get a better drug in this class. The next agent that I think is quite exciting that I think will also have an approval relatively soon is actually a HER3 targeted agent called Trastuzumab deruxtecan, or HER3 DXd. And so this is an antibody-drug conjugate against HER3 with a topoisomerase payload and a cleavable linker. And so HER3 is obviously very important for EGFR signaling, and that's been known for quite a while. And so what they showed in the HERTHENA Lung 01 study, and these were patients, essentially all had seen osimertinib, many had seen a platinum, and actually a platinum doublet, some had seen immunotherapy as well. 51% had prior brain mets and 32% at baseline. So heavily pretreated population. And Dr. Yu presented at this meeting, and what they found was really a significant response rate across the board. In those with both EGFR dependent and independent, your response rates range from about 32 to 37%. Slightly lower if it was EGFR independent, about 27%, but still activity, progression-free survival of 5.5, and OS of 11.9 months, and really heavily pretreated patients. So again, this is likely going to be another option in this patient population. Now, will it fit in earlier lines of therapy? I think that's still an open question, and that's actively being explored. The other thing that we all worry about is, again, brain metastasis, and there was actually very good CNS control with this ADC. So traditionally, we worried about whether we would get good control of CNS disease. The intracranial response rate is very similar to the extracranial response rate, around 33%. Site of first progression, it was 21% of patients with a history of brain mets and 3% of patients without history of brain mets. So definitely a drug that does appear to be active by itself, in this later line setting. So already I've talked about two drugs that it's not much of a speculation that they are under review by the FDA. They likely will gain approval sometime this year, I imagine. There are other similar drugs, so you can think, well, HER3 is a good target. Why don't we combine it with EGFR. So there's actually an EGFR HER3 bispecific antibody-drug conjugate that's being tested called BL-BO1D1. Again, very early days in this, but presented at AACR and ASCO this year, and in kind of heavily pretreated patients who had received osimertinib, platinum doublet, a very nice and kind of robust response rate. We'll see how that holds up in larger data sets, but the response rate was over 60%. So again, yet another agent that I think further down the road may have options. And then the final agent I talked about was actually not really directly targeting EGFR or something the EGFR pathway, such as HER3. It was actually a drug that's been tested in bladder and other cancers and is being tested in lung. A drug called Datopotamab, deruxtecan, or Dato-DXd, which is a TROP2 ADC. So TROP2 is a tumor antigen that's expressed in a number of tumor types. It is actually interestingly expressed more commonly in EGFR-mutant disease. And so this was tested in, again, a heavily pretreated population. 72% had greater than 3 lines of therapy, 51% had brain mets, and 60% have more than 2 TKIs. So the question is, what do we do after we've kind of run through the obvious options? And I'll say they actually had a reasonable response rate in the TROPION-Lung05 study. Again, 78 patients with EGFR mutant and response rates of 43%, duration response of 7 months, PFS of 6 months. And so I think that's when we're getting to the setting where we're talking about using, single agent chemotherapies. I think that seems to be promising data. We'll have to see with kind of in the phase 3 and if they have in later studies, if they actually have, if this holds up. And so, again, that was kind of, for the most part, the drugs that I did cover. I did briefly touch on, since I was covering non-TKI-based therapies, really kind of the emerging role of immunomodulatory agents in EGFR-mutant disease. The short answer is there's nothing yet that is close to approval, but as we know, EGFR mutant patients do not respond to PD-L1 or PD-1 or even CTL4 single agent. There is some small benefit seen with this IMpower015 regimen where you had carboplatin, paclitaxel, bevacizumab, and atezo, at least in subsets of these with sensitizing EGFR mutations. We do have the survival data for that now, although a subsequent trial, which called Atlas, really did not see an overall survival benefit, although their comparator arm was different and it was in an Asian population. But there are a number of drugs that are being explored in this space, immunomodulatory drugs in this space. And we'll discuss that briefly in my talk, but nothing that I think is close to being practice changing today, but maybe hope for the future.